But I have not seen. अच्छा ऊपर से ठीक है. Let's start. Hello. Good morning, friends and colleagues. Yeah. Friends and colleagues, it gives me a great pleasure to welcome you all on today's CME on oncology, organized jointly with Mumbai Oncocare. Our today's CME is in hybrid format, in physical format here at Krishna Palace Hotel and at YouTube platform. We were successful in holding hybrid CMEs in December and November 21 at Sir H.N. Reliance Foundation Hospital and the YouTube platform. But because of Omicron, we were forced to revert back to the webinar form. Today again, we have come in this hybrid CME. In these times of COVID and pandemic, many other very important subjects have taken a back seat. Our today's CME will focus on oncology and some very common malignancies we encounter in our day-to-day practice. I am thankful to Dr. Anil Mehta, Dr. Jawahar Mukhtiar for expertly selecting different specialties for CME, enhancing our day-to-day knowledge and experience. I am thankful to Dr. Rushin Mehta for moderating this session. I welcome Dr. Sandeep Ravindra Gaikwad, who is the MMC observer for today. I am thankful to Mumbai Oncocare and Dr. Vasisth Maniyar, a very well-known and popular oncologist in our city, and his team of oncologists. Dr. Shima Jagasi, Dr. Udit Maheshwari, Dr. Sitish Joshi, addressing us on various different malignancies. We are fortunate to be joined by the Bombay Medical Union, GPA, FFAPI, and the Bombay A-Ward Medical Association. I now hand over to Dr. Anil Mehta to further the proceedings.
Good morning and welcome to the most popular CME of the Bombay A-Ward Medical Association and participating other associations. And today's our host is the Mumbai Oncocare and Dr. Vasisth Maniyar's team. We recently celebrated World Cancer Day on 4th February. This is to raise awareness, to encourage prevention, early detection using battery of investigations, and it will be followed by treatment of different modalities. So this particular awareness is created every year on this World Cancer Day. And by taking this cue, we are also going to have a series of CMEs. The next one is going to be on 20th of February, this month only, and it will be 30th of March. Aspects of cancer from prevention to palliation. We as primary care physicians have a major role to play at each and every step of the disease. Recently, I was part of an initiative taken by none other than Dr. Anita Borges from Indian Cancer Society. And we had made a small capsule. It was a small documentary film, which is now being screened at so many various platforms, where a middle-aged woman enters my busy practice in the busy time of practice. And just she is narrating her symptoms, which were vague, and mainly it was a backache. And then through the different specialties and investigations, we will take all the doctors through the entire process. That the backache, we have discussed the anemia. After that, we went through the entire profile of multiple myeloma, and ultimate diagnosis came out. It was a metastatic breast malignancy. So from a simple backache, if we are vigilant and if we take the patient through a proper diagnostic channel, we can really look for the cancer diagnosis. So I was just thinking the idea is to encourage the family care and primary care physician to look for possibilities of cancer in busy OPDs and prepare them for handholding for all those long term throughout this patient when they go through their financial, social, and this is a very crippling disease which lasts their life. So it is our responsibility as primary care physicians, if we are aware of the disease, if we can sail them through, and they have tremendous confidence in us, and we should be the link between the consultant and the patient. So with this thing, I we will take forward to this. The first program is on chemotherapy. And chemotherapy, we would like to discuss at length in the sense that we have a primary chemotherapy, we have an adjuvant chemotherapy, we have a neoadjuvant chemotherapy, and we have a palliative chemotherapy. So on and so forth. So how differently a patient can be offered, and unless we as primary care physicians are not aware of all these aspects of the treatment, we will not be able to create confidence in our patients. So with this thing in mind, I'm going to have this series of 3 CMEs back to back, and please tune to us regularly. I will hand over the mic to Dr. Rushin Mehta to take further.
Good morning, everyone, and thank you for tuning in today for the beautiful CME that we have on oncology. Thank you, Dr. Anil Mehta and Dr. Kamlesh. Series of Cancer Update 2022. Today we are with us 3 great excellent oncologists from Mumbai, from the Mumbai Oncocare. We are with us is Dr. Shima Jagasi, Dr. Udit Maheshwari, and of course, Dr. Vashisht Maniyar and Dr. Kshitij Chandrakant Joshi. We're going to be dividing the entire day today between a few lectures. Dr. Shima Jagasi is going to be talking upon recent advances in management of breast cancers. Dr. Udit Maheshwari is going to talk about changing paradigm in the management of ovarian cancers. We have Dr. Kshitij Joshi, who is going to talk about dimensions of familial cancers. And lastly, we have Dr. Vashisht Maniyar, who's going to be taking a case-based discussion. I hope we're going to have an excellent, entertaining session during the entire time. We all have had some cancer in our families or friends close by. And the moment we hear the word cancer, we always get completely bogged down by the entire thought process. Recently, I had a lady who came to me with gastric upset. She was having belching, and she's 58 years old, and she had absolutely no comorbid illnesses. And she just had 1 year ago an endoscopy, which was absolutely normal by one of the very good gastroenterologists. And when she came to me, I honestly thought it was just acidity and gas. I honestly did not think of anything else. But the symptoms went on for more than 5 days, and I insisted upon getting further investigations. And luckily she did, because mostly people don't come back so quickly for just gas or acidity. And then she was diagnosed with an esophageal tumor. And of course, now she's going through the entire treatment process. But the entire 48 hours that the family went through during the time that they realized that there's a tumor, to understanding what is the spread of the tumor, to understanding the disease in the biopsy, to understand exactly how bad is the tumor supposed to be, and what is it going to do for the next 6 months or 8 months or 1 year of their lives, and of course for the next 10 years of survival rates. That 48 hours were the worst 48 hours a family could follow. And I was holding hands as much as I could on my end, and I realized how daunting that entire 48 hours can be, till the first consult happens where the doctor tries to play it completely out in the open, trying to be a bit safe so they don't scare the patient beyond the brains, but also enough to be there to explain that this is not going to be a major problem, but we need to go through all the hoops to get to the end. And that power itself, what we have to explain to our patients, is something that we've received, which we should give in a much more better way, in something simpler than what we understand. The one line that the doctor told me yesterday, I still remember. The fear of cancer is a fear of the unknown. So when we have no fear of when we know the fear, then the fear is far less. So with that, I would like to hand over to Dr. Shima Jagasi, our first speaker. She is a special Saikia, a renowned oncologist. Prior to that, she completed her DNB in general medicine from Breach Candy Hospital, Mumbai, and MBBS from the renowned Terna Medical College, Mumbai. Dr. Shima has a keen interest in treating solid tumors like breast cancers, ovarian, lung, cervical, gastric, and colorectal cancers, and hematological cancers. Sorry, my medical knowledge of oncology is a bit less, but I don't know which one she doesn't do. Her entire, she works mainly at the MOC's Chemist Corner. Dr. Shima Jagasi is mainly sitting there, and also has honorary attachments with HN Reliance Foundation, SAIFI, and Just Look Hospital. With this short introduction, of course, I will leave it to her to guide us on the next topic. Thank you very much. Have a nice day.
Today, I'll be talking about recent advances in breast cancer. But before coming to recent advances, first we'll discuss about, we'll have a small interactive session, like when a patient presents to a family physician or a primary care physician with various symptoms, how to evaluate and how to approach a case which may finally lead to diagnosis of cancer, and then comes the management and recent advances. So whenever a patient, a female, comes with a lump in her breast, as we all know, the breast lumps which are cancerous are mostly painless, or they may come with the other signs or symptoms of metastatic disease like weight loss or backache, which need a proper evaluation. And history taking is the most important aspect when we are evaluating any patient. And after detailed history taking, when we evaluate, the important investigations in breast cancer patients are mammography, core biopsy, and PET scan wherever needed. So core biopsies have now replaced FNAC. So wherever possible, we should of the cancer. PET scan is indicated not in all patients, but in locally advanced breast cancers or when we are suspecting metastatic breast cancer. Based on these investigations, we'll stage our patients to early breast cancer, that is stage 1 and stage 2, locally advanced breast cancer, that is stage 3, and metastatic breast cancer, that is stage 4 breast cancers. So this is the TNM staging of breast cancer. Now coming to types of breast cancer, grossly, we have two types. These are the most common. The most common is invasive ductal type of breast cancer, and other type is lobular carcinoma. Lobular carcinoma has more propensity to spread in serous spaces, like it can cause ascites, intestinal obstruction, and peritoneal nodules in cases of breast cancer. The most common type which we encounter is invasive ductal carcinoma. So on this core biopsy, we get the information whether it is ductal or lobular carcinoma. Other test which we advise in all the cases of breast cancer on core biopsy is the IHC testing, mainly for ER/PR, HER2, Ki67, and sometimes androgen receptors. The first three markers should be done in each and every case of breast cancer on IHC, because these will decide the entire treatment protocol of every breast cancer patient. Then there are some special tests which are not indicated in all the patients, but in some specific case scenarios. These are genomic signatures like Oncotype DX or MammaPrint or EndoPredict, the role of which I'll explain. And these are done on the core biopsy or the tissue samples. Then there are specific tests like BRCA1, BRCA2, gene testing, HRD panel, which can be done from blood or the tissue. And then there is NGS testing, that is the next generation sequence testing, which will give the entire information of the breast of any cancer from the tissue. So with these genomic tools, we can analyze the cancer at the molecular level, and we can get the entire information about a particular cancer, because every breast cancer patient is not same. There are various types of breast cancers, and the treatment differs in each and every case. This is on IHC testing, whether the patients are cancer is ERPR positive or HER2 positive or HER2 negative. So now grossly, based on this ERPR and HER2 information on the biopsy, we have 4 molecular subtypes of breast cancer. These are luminal A, luminal B, HER2 enriched, and triple negative breast cancer. So luminal A is by far the best type of breast cancer. It is ERPR positive, HER2 negative, and these have low level negative, but they have higher levels of Ki-67. Hence, they have slightly faster growth rate than luminal A cancer, and their prognosis is slightly worse than luminal A type of cancers. Third type is HER2 enriched, which are ERPR negative and HER2 positive. So these have different target than the first 2 cancer. They have HER2 target. So accordingly, we use the drugs or targeted approaches in this type of cancer, which are against the HER2. So these HER2 enriched or HER2 positive malignancies also have faster growth than luminal cancers, and they do worse than ERPR positive cancers. Fourth type is the triple negative breast cancer, which is the worst type of breast cancer. In this, ERPR and HER2, all 3 are negative, and these are very aggressive tumors. They tend to occur at younger age groups, and this type of cancer is more commonly associated with BRCA1 gene and BRCA2 gene mutations. So based on the IHC report of these tumor markers, ERPR and HER2, we have various permutation and combination of various types of breast cancer, and so accordingly, the treatment of every breast cancer patient differs. Some they need hormonal therapy, some they need anti-HER2 medicine, some they need chemotherapy. So the treatment, mainly the chemotherapy, can be divided into 3 settings. That is the neoadjuvant setting, adjuvant, or metastatic setting. Neoadjuvant chemotherapy is when we give chemotherapy to locally advanced breast cancers or inoperable breast cancers to convert them to operable cancer. So when a patient is having a large breast lump or a lot of axillary nodes which cannot be operated upfront, we give them neoadjuvant chemotherapy to downstage the cancer and then make it operable. And then after giving neoadjuvant chemotherapy, the patient is sent to surgeon for surgery, and remaining chemotherapy can be completed in the adjuvant setting, that is after the surgery. So the role of neoadjuvant and adjuvant settings . So in both these neoadjuvant and adjuvant chemotherapy, the intent to treat is curative, to cure the patient of the cancer. But when we give the chemo or any treatment in stage 4 cancers, the intent to treat is palliation, that is to improve the quality of life of the patient, and where we can only control the disease but cannot cure the disease. So in ERPR positive breast cancers, we mainly treat them with endocrine therapy, with personalized, here we can give personalized therapy to the breast cancer patient based on which mutation is present in a particular patient. So if a patient has PIK3CA mutation, which can be detected on blood sample or tissue samples, then this drug called alpelisib can be used, and those who don't have this PIK3CA mutation, in that this drug will not be useful. Then ovarian suppression or the suppression of ovarian hormones is also very important in the hormone-driven breast cancer. Then in HER2 positive breast cancers, we have the drugs like trastuzumab, pertuzumab, lapatinib, TDM1, neratinib. These are the drugs which specifically target this HER2 on the breast cancer, and hence this can be used only in patients whose breast cancers express this HER2. In triple negative breast cancer, they don't have any target like ERBR or HER2, hence chemotherapy forms the backbone of treatment of triple negative breast cancers. And now, even in the treatment of triple negative breast cancers, there have been advances in the management, that is, the PARP inhibitors have been found to play important role, particularly in the triple negative breast cancers who are BRCA1 or BRCA2 positive. These help to control these cancers. And last but not the least, immunotherapy. Immunotherapy is the upcoming, is already there now. It is also helpful. These are the monoclonal antibodies. These are also helpful in this deadly disease called triple negative breast cancer. So here now the breast cancer care is getting more and more personalized branch of medicine, in which each and every patient will benefit from a particular therapy which will not be effective against other patients' breast cancer type. So now the mortality rates in the breast cancers are reducing annually because of mainly early detection and new treatment or recent advances in these methods. So there have been advances in evaluation, diagnosis, workup, treatment. There have been advances in the medical oncology treatments. There have been advances in surgical techniques. There have been advances in the radiation techniques. Today, we will mainly discuss about the recent advances in the medical oncology. One another important aspect in breast cancer patients, which Ms. Divya will elaborate in her presentation, is the genetics. So with the genetic tests, we can identify the patients who are at high risk of developing breast cancers. And because all breast cancers are not sporadic, 5 to 10% of them have the genetic . So genetic tests are mainly BRCA1 and BRCA2. There is HRD panel, and which will help in finding out about the higher chances of developing breast cancer. And these genomic tests like Oncotype DX, which is a 21 gene assay on the tumor tissue, it will give these are the prognostic and predictive markers. So prognostic markers means which patients will have the tendency for their cancer to recur even after treatment completion, and predictive benefit means that who will benefit from cancer chemotherapy and who will benefit from hormonal therapy. That also we can find out from these assays. Now these genetic testing like BRCA1 and BRCA2 from blood or from tissue, mainly from blood, can be done in home. So patients who are diagnosed with breast or ovarian cancers at younger age, that is less than 50 years of age, those who have triple negative breast cancer, those patients who have 2 breast cancer primaries, or those who have ovarian cancer, those who have like male breast cancer, they should be subjected. And breast cancer at any age with 1 or more relative with breast or ovarian cancer at age 50 or younger, 2 or more relatives with breast or pancreatic cancer, and in women of Ashkenazi Jew descent at any age. And when a patient has past history of some other malignancy, also in the past, like thyroid, sarcoma, adrenal. So in patients who are suffering from two malignancies, so they also can be subjected to this genetic testing. So 1 in 7 women have chance of getting breast cancer in their lifetime, and most cancers are sporadic, but 5 to 10% of them are genetically linked. So women inheriting this BRCA gene also have increased chance of this disease, and they can also lead to various other cancers apart from breast cancer, like ovarian cancer, pancreatic cancer, and in males like prostatic cancer. This all Divya will discuss in her presentation. So based on this genetic testing, genomic profiling of tumors, these are making the decision making very personalized in the breast cancer patients. And also there are some risk reducing surgeries. For example, if a patient is diagnosed with these BRCA1 or positive with BRCA1 or BRCA2 genes, then they may be advised about these risk reducing surgeries in the form of oophorectomy, so that in future then the risk of getting ovarian cancers are minimized. So thank you for patient hearing. And like Oncotype DX, MammaPrint, or EndoPredict, these are also the genomic signatures which are done on the tumor tissue after surgery. So these are done in patients with early breast cancers to know that whether this patient will need chemotherapy, or they can only be managed with hormonal therapy itself. Means only with the hormonal therapy when there is no significant advantage of adding chemotherapy to these patients. So whenever chemotherapy advantage is not much, we can only manage these patients after surgery or straight away on hormonal therapies. Yes, we collect that tissue and then we send to the specific labs where it is processed. MammaPrint, Oncotype DX, all these are done abroad.
Thank you, Dr. Shima. See, with this talk, we can imagine that each and every case with a breast cancer, they are unique by itself. They have a different progression life, different modalities of investigations, different modalities of treatment, so on and so forth. So unless we know the entire gamut, how this breast cancer is going to behave, like we have gone to the extent, and right now, I personally feel that the breast cancer has been very well understood, and probably it has the best chance of management and cure rate. So with these words, thank you for, and I will also take up the surgical management and later on during our next CMEs. Now, next lecture is on recent advances, changing paradigms in management of ovarian cancer. We have with us Dr. Udip Maheshwari. Dr. Udip Maheshwari completed his MD General Medicine from Rajendra Institute of Medical Sciences, Jharkhand. Did his DNB in Medical Oncology and Hemato-Oncology from the renowned Rajiv Gandhi Cancer Hospital and Research Center, Delhi. He has earlier done his MBBS from Tehran Medical College, Nerul, and resident of this internship from KM Hospital, Mumbai. Udip Maheshwari has a special interest in targeted therapies and immunotherapies in cancer treatment. He is trained to treat and have hands-on experience in treatment of breast cancer, lung cancer, stomach and colon cancer, prostate, bladder and kidney cancers, and blood cancer under hemato-oncology segment. Dr. Udip Maheshwari is also trained in handling all oncological emergencies. He is currently at Mumbai Oncocare, Global Hospital Parel, Koinur Hospital, Kurla, Hindu Mahasabha, Ghatkopar is an honor.
Good morning, Sunday morning. So many people. I thank you all for coming here. Till they load the presentation. Great. So I think my job would be cut out because most of them have some or the other experiences with ovary. I'll just need to streamline the approach. Finally, it's done. Now, you can keep it. Thank you. Okay, so we'll be discussing certain clinical pulse and management of ovarian cancer. Now coming to the next slide. I know we all know her, Manisha Koirala. And she is Nafisa Ali. If you know Life in a Metro, she's a very common actor here in their place, secondary roles. So this is a shot from Life in a Metro. Anyone knows this female? So why am I showing these females? Anyone knows this female? She's Kobe Smulders from How I Met Your Mother. Very common. So I'm showing her because they all fought cancers and they fought it with a smile. And they all were ovarian cancer victims. Kobe Smulders got affected by ovarian cancer at 25 years. So it's really sad, but then they all fought and they're all here. So coming to ovarian cancer incidence and mortality. Now, if we see the Indian data of ovarian cancer in females is around the third most common cancer, accounting up to 6.7% of the incidence. If you see the mortality, out of 6.7%, 4.8% will end up succumbing to ovarian cancer, which is a very high. Top 3. Now, some facts about ovarian cancer. If you see, white population is the most commonly affected. Then Asian population has 9.1% incidence. So very important facts that many of us have some myths about it. Ovarian cancer is 10 times more deadlier than breast cancer. It is, as I told you, the mortality is 70%. Pap tests do not detect ovarian cancer. There is no current screening for ovarian cancer. If you had hysterectomy, you may still be at risk of ovarian cancer. So even if you have had a surgery, then also ovarian cancer and fallopian tubes are the ones that can get affected. 70% of the ovarian cancers do not discover their cancer until, so that is why most common presentation is abdominal distension, wherein the stage is advanced. So 70% of these cancers will have recurrence of the cancer even after aggressive treatment, and 70% of these women will succumb to ovarian cancer. So as you rightly said, the symptoms of ovarian cancer we'll be discussing. So it's very common, where B is bloating that is persistent, eating less than and feeling fuller, abdominal pain, and trouble with your bladder. So these are common symptoms that ovarian cancer patients may have at presentation. So these are symptoms in a female of 40-50 years of age. If you have these symptoms, there should be some at back of your mind that these things are also there, and we should be able to rule this out. So suppose, let us discuss a real life case with the symptoms here. So a 55-year-old female presented with abdominal pain and distension, reduced appetite, generalized weakness. On clinical examination, had ascites, that is, at fullness, flanks full, passes motions and urine adequately, vitals are normal, and outside sonography shows an adnexal lesion. So this is the most common presentation that you will get with an ovarian cancer. If the symptoms come, you get a sonography and you get some adnexal lesion, some cystic lesion that is there in the adnexa that is mentioned, and plus minus ascites you can have. So what next that we do? We do a routine workup of CBC, KFT, LFT, and ECG. And what are the specifics that we need to do and see when you see an adnexal mass? Is CA125, which is a marker that has been secreted by the ovarian cells. And these markers are increased in ovarian cancer. Not necessarily every time it is increased, but yes, it is a marker that is specific to ovarian cancer per se. CT abdomen and pelvis is very important because we do that to understand understand where all the disease is spread in the abdomen. Are lymph nodes affected? Is peritoneum momentum affected? All of that. Endoscopy, colonoscopy. Why is that important? I'll come to at the fag end of my. Okay, so in this case, what we did was a PET scan. Instead of a CT scan, we did a PET scan. We understood that this may be an ovarian cancer. We did a PET. which showed us that there was a adnexal mass, there was omental thickening, there was ascites, there was also pleural effusion, and CA125 was raised. Normal value ranges between in the range of 35. CA125 was 4,100, which was very high. Ascitic fluid tapping was done, and that cytology showed serous adenocarcinoma cells. So this is the basic work of basic diagnostic that we do in most ovarian cancers. And this is the most important part for all of us, because, you know, as family care physicians, they would want, you know, certain answers from all of us. What is it? What is the survival? Because those restless nights, as Roshit sir mentioned, that, you know, 48 hours of restlessness can be allayed to a certain extent if we know, if you know, we have this thing in back of our mind. So what are the management options? Before coming to management options, I want to discuss these things. So anything that, you know, management options, how do we manage? So basic 3 pillars of oncology, what we say is chemotherapy, surgery, and radiation therapy. However, radiation therapy is not much help in ovarian cancers, but chemosurgery and the newer paradigms that you're going to speak about is target therapy and immunotherapy. We'll come to that at the end of the talk. So chemotherapy and surgery being major pillars of treatment in ovarian cancers. Now coming to chemotherapy and surgery, as you know, it was mentioned in the breast cancer talk by Dr. Shima that we have neoadjuvant, adjuvant. Even Anil Mehta sir, said that in his introduction, that there are neoadjuvant settings, adjuvant settings, and all of that. So those settings are important in ovarian cancer because we try to debulk the disease, then do a surgery, and then again give an adjuvant setting chemotherapy so that the disease does not come back or comes back at a later time. So the drugs that are important is non-platinum, platinum, taxanes. So these are common terms that we should know, that platinum chemotherapy, taxane chemotherapy, paclitaxel, carboplatin. These are 2 terms that you commonly hear in many of the cancer patients, because most common drugs that have been used in cancer chemotherapy. And what about surgery? So surgery, if you see the right side, this slide is very important because, you know, it shows that what you need to do as a surgeon. As a surgeon, if you want to remove everything, you have to remove, restrict the uterus, you have to remove bilateral salping oophorectomy, that is the ovary and the fallopian tubes, you have to do a peritoneal washing, you have to do a pelvic biopsy, you have to do an infracolic omentectomy. It's not just about removing the ovary. It's removing everything and taking biopsies from everything else so that we don't miss out anything. So this is something that is important for us to if you see the stages, if you see the distant metastatic stages, they are very high. 59% of patients will present with a distant metastasis, and the survival goes down as the metastasis increase or as the metastases have increased. Right. So 5-year survival in ovarian cancer stage 3, stage 4, if you see, is just 19%. It's not. It's a very dull number, you know. And ovarian cancers, though, are initially present in an earlier stage and can be treatable, but most of them will recur, most of them will have problems. So these patients would be very chronic patients for us. So that is why it is very important to catch this disease at an earlier stage and, you know, try and help these patients in a better way. So again, this picture cartoon depicts the same. The 5-year survival in stage 4 disease is hardly anything. Half a lady shaded there. Now, anyone has any? So I think Dr. Divya would, enlighten us on this again. But anyone who knows BRCA mutations, BRCA1, anyone? Very common term used in oncology world, because breast and ovarian cancers are the most common cancers that we see. So BRCA1 are genetic mutations that lead to breast and ovarian cancers, right? So we have DNA in the body that controls everything. A DNA will repair itself every time. There are mechanisms for these repair. So if these mechanisms go bad, the repair does not happen in a proper way. And if the repair does not happen in a proper way, there are mutations that happen, and these mutations will lead to cancer. So if this repair does not happen, then so BRCA is a repair mechanism gene. So if this is damaged or mutated, which is very hereditary, even in fact, some families have BRCA mutations that are hereditary. So they will be prone for breast and ovarian cancers. Most commonly, there are other cancers also, a long list of cancers, but breast and ovarian cancers are most common in these mutations. How many? So these are younger female coming with ovarian cancer or a younger female coming with breast cancer will definitely ask you these questions. Is my family at risk? Or my mother has it, I am having it at a younger age, will my daughter have it? So this is very common mistakes. But will all inherit? Not all genetic traits are inherited, right? As we rightly see. So it's the same there, right? So not all mutated BRCA will be given to the family in 55 to 60%, and only 50% of them will have breast cancer or ovarian cancer. So that is how not all patients will, even if they have a mutated gene, will have a cancer in their lifetime, right? So this is and we can increase the survival by 1 or 2 years also. So ovarian patients who are relapsing within a year, within 2 years, they may have 1 additional year of cancer-free interval with these pills. So that is why it becomes very important in my talk as a recent paradigm shift in ovarian cancer. Because if you see oncology world and ovarian cancer, there is mention of olaparib throughout from the beginning to the end. So olaparib is the new kid on the block in ovarian cancer, right? So if you see the chart, the death rates were niche. The patients who not used olaparib, the graph has gone down like Sachin Tendulkar's batting had gone down in 2015-16, but the drug has has shifted like Virat Kohli and is putting in centuries after centuries. So the line above is up, the line below is up. That shows the difference of survival with olaparib, right? Now, what are the other advances? We've discussed about olaparib, we've discussed about chemotherapy basics. What are the other advantages? What are the other newer paradigms that have changed? So chemotherapy initially in 1940s, 50s were only single, I think handful, 5 chemotherapies probably. The book that we used to read called Devita was just 30-40 pages ka book tha. Now it is 2 volumes. So there are only 5 to 6 chemotherapies begin with. So eventually they realized that adding 2 chemotherapies together had better response rates. Then they said that 2 chemotherapies have more side effects. Let us shift to weekly regimens. So weekly therapies had better responses, fewer side effects. The newer molecules came up. Newer molecules had better response rates. Then newer supportive care came up. So there was vomiting that was the peril in chemotherapy. Vomiting, nausea. That was now we have newer drugs that can control that, and I think less than 1% of our patients have nausea, vomiting during their chemotherapy. Lastly, there are Paxman's calculating system has come up, which has less of hair loss. So even hair loss, which is there in females of 40-45, probably they want to attend marriages at everywhere. That is the age to attend marriage and show off their skills, but then with hair loss it becomes difficult. So we have Paxman for that now. So that prevents hair loss, and during chemotherapy, and they can attend all the marriages that they want. So that is very important because it helps them have that self-confidence, maintain their routine activities, and take their mind off the disease. So that is very important. So these newer therapies have made things simpler, and chemotherapy is not the devil anymore. Newer targets that we're talking about, PARP inhibitors, we've already spoken at length. We'll speak about 2 more things. One is Bevacizumab. in 2001, and this drug was developed called Bevacizumab. These drugs, they will target the vessels. They will target the vessels and kill that new vessels that develop in the tumor. So this is the vessel. These are these factors that are helping the tumor grow, and we have a drug that kills those factors, and the blood vessels will perish, and so will the tumor. So that is a simple explanation about how this drug acts. This is called targeted therapy. It may not have the same side effects as chemotherapy, may have certain different side effects, but they are not to the tune of what chemotherapy does. So they become easier. The other oral tablets that have come up in ovarian cancer are lenvatinib, pazopanib. They have also shown some benefit in these cancers. And we may shift from chemotherapy to targeted therapy and now to oral therapy in the near futures to come. So I think you will be the last. We all will be the last generation using chemotherapy, probably. But that is what I feel. So let's discuss one more case. I think mostly the topic of discussions have been discussed. I will just finish off with a case, one or two cases. A 33-year-old female patient presented with abdominal pain, symptomatic treatment given. Pain was persistent. USG whole abdomen was ordered, and there was a bilateral adnexal mass. Suppose this patient presents to you on a busy evening schedule. What would be your treatment, or what would be your this? Anyone?
CA-125.
Yes, sir. And CA-125 was CT abdomen. Yes. So CT abdomen, CA-125, as we rightly spoke, was done. CT abdomen showed a adnexal mass and no disease elsewhere. CA-125 was borderline, right? So what next? Are we clear that this is an ovarian cancer? So it was not. It was an ovarian cancer, but CA-125 was not raised. So as I told you, it is specific for certain ovarian cancers. It may not be very specific for all cancers. So biopsy showed a mucinous adenocarcinoma. Is it an ovarian cancer still? Anyone? So I had said in initial that colonoscopy and endoscopy I'll come to in the next part, last part of my discussion. So colonoscopy and endoscopy was ordered, and there was a large ulcer in the colon. And that biopsy of colon showed mucinous adenocarcinoma. So this was a lady presenting with adnexal mass, but ultimately came out to be a colon cancer with metastasis in ovary. So these are commonly called as Krupenberg tumors, and ovarian cancers are most common differential is Krupenberg tumors. That is why we have to look at the GI system and the colonoscopy also. So this case turned out obvious, may not be so obvious, right? So to conclude my talk, gynecological cancers in the world are on rise. Delayed diagnosis is a major concern. Treatment options, there are multiple neotherapies available now. Chemotherapy drugs are now better with better regimens, fewer side effects, and better supportive care. Targeted therapy is the future. Olaparib is leading the way forward. I thank you all for your patient hearing. I hope you enjoyed the talk. Thank you. Questions will take it. Yeah, tell me. Asymptomatic presentation. So most of them, we don't have a screening program to understand the percentages of asymptomatic patients, right? So we don't no female does an ultrasound of the abdomen every 3 months. So most of them will present with some or the other abdominal discomfort. That is what they would present with. So asymptomatic patients will only be identified if you have a screening program for that. So suppose pap smear, cervical cancer, we have pap smear program and we identify these patients then, but we don't identify other, these patients where there is no screening program. But most of the patients, I think in my practice, I see around 60 to 70% of the patients presenting in stage 3, stage 4 ovarian cancer. Most commonly stage 3.
So the important message in the last case, which you mentioned, is something that all of us need to learn about. Is typically ovarian cancer comes as a unilateral large ovarian mass. Whenever you have bilateral ovarian masses and your CA125 is normal, do not jump for an upfront surgery, because this patient otherwise would have undergone a bilateral oophorectomy with hysterectomy, and then you would have realized that you've not even treated the primary cancer and the disease will come back. So whenever the CA125 is normal, and when you have bilateral ovarian masses, always keep a differential of Krupenberg tumor. This could be coming from the stomach or the GI, the duodenum, colon, or the large intestine. These patients should not be subjected to an upfront surgery, because then you are giving them an incomplete surgical resection. This is actually a stage 4 CA colon with ovarian metastasis.
Absolutely, absolutely. So that was the message that was important, because we jump onto sometimes as oncologists also, when we are busy, we jump onto conclusions with basic reports that we have on board. But it's important to think have these differentials in our mind. Any more questions? Yes, sir. Oophorectomy. So it depends on what family history. So suppose if you have a BRCA mutation, there is BRCA1, BRCA2, two kinds of mutations. So all of them have a different age group where they develop. So BRCA1 has an age group of 35 to 45. Oophorectomies to prevent your cancer happening, and in BRCA2 you can get it at the age of 40-45 years also. So these are the basic guidelines that are there for these are called risk reduction surgeries. So they reduce the risk of a person getting cancer. So these are not helpful in patients who have already had cancer. Yes, they are helpful. Suppose a patient has a breast cancer, they can do a risk reduction surgery of the ovary also if they are mutated. So that can be there. I think Dr. Divya would be the right person to elaborate more on that, because it's her talk that's going to help you with understanding the hereditary cancer. But these are the things that are important, right? Anyone? That's it. Thank you. I hand over to sir. Thank you, sir.
Thank you. It was a wonderful presentation. While I was listening to me, I thought that I will share a couple of things which comes to my mind. The first and foremost is this chemotherapy, when we are using this adjuvant and non-adjuvant. When we have a primary cancer which needs only chemotherapy, like lymphoma, it's a primary chemotherapy. When we do the surgery of a cancer, and which we follow it with a chemotherapy to complete, we call it adjuvant chemotherapy. When in the beginning, when we encounter a cancer and we don't find that it is operable at present, we give a neoadjuvant chemotherapy, downsize the disease, and then we follow it with the surgery, that is neoadjuvant chemotherapy. And with an advanced cancer, sometimes we use chemotherapy to alleviate the symptoms of pain, etc. That is palliative chemotherapy. So just to mention that. Another thing, I try to give analogy to my patients when they first come with cancer to me. It's a little different discussion, that you can consider cancer like a war, in that you have an army, you have navy, and you have air force. So army is our surgery, navy is our chemotherapy, that is a fluid, water, and air force is like radiation. So when you have to fight with Pakistan, you might have to use all three modalities. But if you are fighting with some neighboring country like Nepal, you don't need navy, you need only air force and the army. So likewise, there are different combinations are used to cater to the different distinct. Now, the third important observation which I would like to make, that the newer and the younger doctors are very smart, and they are much smarter than the older ones. So I would put that there is something known as reverse inheritance, which you'll have to put next time in his slides. And lastly, the next topic which we are going to discuss, which is on genetic and this thing. So what is happening here? Yeah, what is happening here is that everyone understands now genetics. We know from the experience of Delta virus and Omicron virus and all that, we know what is mutation. Even the lay public now know about mutation and genetics. So we are now aware of it, but let us discuss our seriousness about the cancer part of it. So may I call upon Dr. Govind Nichlani he will be introducing Dr. Kshitij Joshi. He is from the A World Medical Association.
Good evening, all the speakers. Good morning, all the speakers and the doctors who are today for the CME. It's my privilege to introduce Dr. Kshitij Joshi, the next speaker, who will be speaking on familial trends in cancer. Dr. Joshi did his DM in medical and pediatric oncology and hemato-oncology from the Gujarat Cancer Research Institute, Ahmedabad. This is one of the largest cancer care center in Asia. He did his DNB in medical oncology from the National Board of Examination in Delhi. He has cleared his ESMO, that is a European Society of Medical Oncology certification examination. He has various publications in national and international journals and has a strong inclination in teaching. He also has special interest in immuno-oncology and has attended various programs conducted by ESMO. Dr. Joshi.
Thank you very much for this kind introduction, Dr. Kshitij. And first of all, I will thank all esteemed members of the Mumbai Sea Board Association for giving me this opportunity to speak in front of you. And today's topic is very interesting. So the topic given to me is a familial cancer. So I will start with a few examples that we usually face in day-to-day life, in day-to-day our clinics. So in last 2 to 3 months, I am just giving you 2 simple examples because the familial cancer, sometimes we feel that it is not so common. Or sometimes we feel that what is exact the percentage and that we are getting this familial cancer. So initially when we started our practice, we were thinking that it is not so common because the books mention it is just 5 to 10%. So just one example, that one lady was on treatment for adjuvant chemotherapy for triple negative breast cancer. Her age was 45. So initially during our entire investigation, we also advised the protocol to do a BRCA testing and all, but she refused because they do not know the importance. And initially they just say, okay, we will do it later on. So after 1 to 2 cycles, she said that can I bring my mother? She is multiple chemotherapy given, she is treated multiple times in Tata Hospital for ovarian cancer. Can you give your opinion? Yeah, you can bring her. So,
Okay, fine. So that, am I audible? Okay. So the thing is that at that point of time, when there was one person who is a 45-year-old lady having a breast cancer and her mother is having ovarian cancer. So we advise them now it is very, very important. You have a strong family history. Go ahead with the testing. And she did a BRCA testing and she was positive. And while on the day of consultation, when we were giving her what should be done for this BRCA information and all, when the one lady was sitting with her, she was 40-year-old and she was her sister. So just we advise the part of a protocol, as you are a BRCA positive and your sister is there, she should undergo this testing. At the same time, you should undergo
this sonography and CA-125 testing. She was perfectly asymptomatic 40-year-old lady. And this is a real life situation. And to our not surprise to them, but to our side also, there was a small mass in the ovary sitting when we did the USG. She was perfectly asymptomatic, no problem at all, 40-year-old young lady. And then we perform a surgery. We requested an oncosurgeon to do a surgery. It was removed completely, and now chemotherapy is going on. This is a real life example. Second example, I got a call a month back, no, 2 months back, from a very good physician. There is a patient who is around 50-year-old, operated for colon cancer, and now need a chemotherapy. So can you give your consultation and opinion? So no, okay, fine. You send that patient to me. And he just mentioned that there is a family history, because I am treating their family since last many years, and they have a multiple family history of cancers. So can you see that? So okay, fine. So we evaluated that patient and we advised them for a colon cancer, some kind of testing. We requested our genetic counselor to give that opinion, and they just said yes, yes, yes. After 1 month, I got call from the same physician. A lady, she is diagnosed at a 40 years of age, colon cancer, and she presented with intestinal obstruction, and she is cousin of that patient. So that's what I want to, and then she was treated and the treatment is going on. I want to point it out that this is not so uncommon. We are seeing day to day these patients, and which is 5 to 10%, it may be 3 times of that. Dr. Divya madam can tell you afterwards. She's a genetic counselor with us. This percentage are more in Indian population, or we are finding it more, that I don't know. But that data is required for that. But how we'll get a data? That we are working on that. Mumbai Oncocare Center, various centers, we have large amount of data, and we are accumulating that data. We are processing that data, and in recent times we will come up with some real life Indian data with that. So let us come to the topic. So this is a familial cancer. First point: is every cancer is a genetic? Yes, of course, every cancer is a genetic. Genetic and familial or hereditary are different terms. Genetics means there is a defect in the gene, and that defect may be because of various factors. It may be because of this daily pollution. It may be because of the chemicals in our food. It may be because of the substance we consume, alcohol, tobacco, and they are majority are sporadic. Means that is limited to that person only. When it gets transmitted from one generation to next generation, then it becomes hereditary or familial. And the percentage might be vary from 10% and above. And that is a percentage that is very important. Why it is very important? Because here we can do something to prevent the advanced disease in the same patient or in the family members. We can save a life. That life may be some mother, some daughters, some grandfather, anybody. A life is more precious, and we value, everyone here value a life, because we are all doctors. So that is the importance of these things. I will divide it into benefits of this information that we are going to get in this lecture into 2 parts. The benefit to patients and benefit to family members of patients. And when you divide this benefit to patients into 2 parts, benefit for current treatment aspect. So if the patient is BRCA positive, we have one treatment which is called as a PARP inhibitor, olaparib, which is approved now. Rucaparib and other drugs are also available, which can control this disease for longer period of time. So for that patient, the new treatment options may be available. Second thing, if that patient is cured from that particular cancer, like my first example of that lady, suppose she is cured from some left breast cancer, but she still has a high tendency or chances of getting opposite side breast cancer and ovarian cancer in the future. So what she can do, we can guide. Then the family members benefit. Suppose they have the familial tendency and mutations of this cancer, they can take precaution in form of various. What kind of precaution? Early screening. If BRCA positive at the age of 25, we start with the mammography yearly. And if they have completed their family then at between 35 to 40 years, we advise them to go ahead with the prophylactic salpingo-oophorectomy. There is very famous example of prophylactic bilateral mastectomy by a celebrity, Angelina Jolie, to prevent the breast cancer. So why they are going ahead with it? Because this can prevent a cancer at an early stage, and we can do something for that. This is first thing. Suppose it is a colon cancer. Suppose colon cancer, a familial FAP, Polyposis, or there is a non-polyposis, that is a Lynch syndrome. There are two very common syndromes. We can do a colonoscopy yearly or twice yearly or once in 2 years, and we can detect it early and treat it with a curative intent. So lives can be saved. So this is a brief introduction why it is important. And now with the more and more information coming into picture, we are understanding more about this disease, and we can take some action to prevent it or to cure it. Now, this is a very advanced science, genetics, going into that details. And if an expert can give that advice, that will be the most preferred thing. So with us, one expert is in a genetic council. So in a genetic field is Madam Divya Kushi is there. She is with us, and she is a certified genetic counselor. So instead of I am continuing with the same thing, I will request Divya Madam to take over so that she can guide us better. So may I request Divya Madam to take over?
Very good morning to everybody. Firstly, thank you very much, Dr. Kshitij, and everyone for this opportunity. Just give me 1 minute to share my screen. So meanwhile, while we're getting started, I think Dr. Kshitij very beautifully tried to explain us in a very brief way as to how familial cancers, hereditary cancers can actually have a very big impact on a patient's life. So every time I introduce myself as a genetic counselor, I approach the layman saying I'm a genetic counselor. They are quite taken aback, firstly, because it's a very new word for all of them as to who is a genetic counselor. So when they get to know that a genetic counselor is somebody who's an expert in the field of genetics, and I can basically help them predict their future risk for cancers, it somewhat, in their minds, it somewhat looks, excuse me, not able to. Okay, it somewhat looks like this, okay? So maybe they think that we have a room where we have a magic globe and they can come sit across and some quick words, mantras, and we have the risk. Unfortunately, though, the process is very, very long. There's something known as a pre-test genetic counseling, which is the first session that the patient has to undergo, wherein we take a very detailed family history, we take a detailed clinical history of the patient and try to understand if there is any hereditary component that we're able to identify here. Based on that, we can suggest them as to which test would be the best suited test to go ahead with. Firstly, right now, there's so much development happening in the field of genetics that there's not one test which suits everybody. There are a lot of tests which are available. And since these tests are slightly on the expensive side, we need to be very careful about which test we are advising to the patient. Once the patient has undergone the test, it is important for us to share the clinical history for the correct interpretation of the data which is being derived from the DNA of the patient, post which we have something which is called a post-test genetic counseling session. In this post-test genetic counseling session, we basically explain to the patient as to what the genetic test report means, what is the implication for them, and how further whatever risk has been derived out of the report can be managed. So like Dr. Kshitij very rightly told us, what is hereditary is only 5 to 10%. When you look at this whole pie chart made here, I'm sure it looks like a very insignificant proportion because there's so much which is sporadic at the 80%. And there's only 5 to 10% which is hereditary. So, but I want to like re-emphasize on this and, so that we know more about our Indian data and coming to more about genetics in India, this 5 to 10% is the world data, but this is known to be 3 times that of the world data in India. The main reason for this is basically we have a very community specific approach in India, because of which we do not have a very diverse gene pool. Like, marriages usually are within the community, because of which the genes keep rotating inside, the mutations keep condensing themselves within the same community. So that is why the rate of hereditary cancers, like Dr. Kshitij said, that in our everyday practice, we have so many cases wherein some or the other history associated to the patient is definitely found out. So that is precisely because of this particular culture that we follow in our country. Again, you would see that there is, I've differentiated familial and hereditary. There might be a confusion between these two as to what is exactly familial and what is exactly hereditary. So just like to tell you all that there's a very thin line which is between the familial and hereditary aspects, and mostly all of us, tend to confuse between the two of this. Familial are cancers which are cluster of similar cancers in the family. There might not be a one specific reason for these cancers happening in the family, and which is what we say could be an event of chance. That by chance, a mother and a daughter have been diagnosed with a breast cancer, say at later ages. Okay, I'll be explaining this with better examples for clarity on the subject. Hereditary is basically when we have one common reason for all the cancers in the family. And the pattern of cancers, the inheritance pattern which is seen in these cases are very, very recognizable. So here I have 2 pedigrees which will help you understand that better. In the first case, you can see that we have 4 patients in the family with breast cancer. But as you see, most of the breast cancers which are seen, 3 that we know the ages of, are at post 50. Okay, so as we know already that the rate of incidence of breast cancers in the Indian population is quite high. In comparison to the world population, we stand somewhere at 30%. So it could probably be a case wherein these females who have been identified with breast cancer in this family has been an event of chance. Okay. Again, I spoke something about a recognizable pattern of inheritance. If you see very closely in this particular family, which is termed as familial, there is no recognizable pattern, because if we look at the 52-year-old who was diagnosed with breast cancer, her mother is perfectly fine, right? If we're suspecting something which has to be genetic, it has to come either from the maternal or the paternal side. Herein, the mother is perfectly fine. Although the maternal aunt had it, she has another first cousin who's been diagnosed with breast cancer, but her mother is also perfectly fine. Okay, so there's no recognizable pattern of inheritance that we're able to spot here. In very striking contrast, if you see the family with hereditary cancers, first thing to note here is we have all early onset cancers here. Okay, the latest age of onset that we're seeing here is 52 years. Mostly we have somebody at 38 having a breast cancer. We have somebody at 33 having a breast cancer. Plus, we see a very, very strikingly, a very striking pattern of inheritance here. The daughter has the cancer, her mother has it, mother's sister has it, sister's daughter has it, so does the grandmother. So we know that it starts from the grandmother passing on to 2 of her children, and then them passing it on to their children further. So in general, we have a lot of hereditary cancer syndromes which have been found out recently. That's mainly because of the development in genetics, because of which we have a lot of new genes which we know about which could cause hereditary cancers. So there are more than 50 per se. Most of these hereditary cancer syndromes, why do we call it a syndrome? Because you can have a bunch of cancers occurring because of one common reason. Like Dr. Udip already told us that because of BRCA1 and BRCA2, majorly you can have breast and ovarian cancers persisting, but there can be other cancers also which the patient could be at risk of. Mostly they are autosomal dominant in nature. I'm sure all of us going back to our medical days, you must have studied a small subject called genetics, in which we had autosomal dominant, autosomal recessive. Autosomal dominant is where the 50% risk of inheritance comes from. That per se, if you have even one defected copy of the gene, out of the two copies of the gene, if even one of it has a mutation, you are still at risk of getting the cancer. And there is something known as incomplete penetrance, which basically makes the whole hereditary cancer situation a little difficult, outright to identify. Incomplete penetrance is basically, we have cases where an individual can have a genetic mutation, but has not had a cancer yet. So it becomes a little difficult for us to explain to the patient as to, even though having the mutation, how come they do not have a cancer yet, but maybe the next generation has already developed the cancer. Okay, so that's what we call as a case of incomplete penetrance. Out of these 50 odd hereditary cancer syndromes that I spoke of, there are basically 4 which are predominantly seen in our Indian setup and in most of your clinics as well, maybe. So I'll be speaking in detail about these 4. The first one here is the hereditary breast and ovarian cancer syndrome, which is majorly caused because of the BRCA genes. The BRCA genes are a little more popular than the other genes, and the main reason behind it is the Jolie effect, which took place in May 2013, wherein Angelina Jolie underwent bilateral prophylactic mastectomy and a bilateral salpingo-oophorectomy because she was identified with a BRCA mutation. So whom do you actually suspect to have a BRCA mutation? If you have an early onset breast cancer, which is precisely before the age of 50, ovarian cancer at any ages, this new guideline has come up because of the treatment paradigms that we discussed in the previous lectures, that you have olaparib, which can work amazingly well for these patients. So for ovarian cancer patients at any age, you can suspect them to have a BRCA mutation so that you can accordingly try and change their treatment protocols. If you have multiple primary breast cancers in either or one of the breasts, if you have male breast cancer, so male breast cancer is something which I think the layman is absolutely clueless about, because the incidence of this is very, very, very rare. So if any day that you come across a male who has had a breast cancer, then the first test which should be ordered along with the biopsy, of course, should be a BRCA test to identify if there could be any other risk that the male could be at, also to help the family of the individual. If you have a triple negative breast cancer, particularly before the age of 60 years, a combination of pancreatic, prostate, breast, ovary, and a family history of any of the above and more than one of the first degree relatives. So what are the risks? This is basically, I've put in this slide to basically try and bring out the importance of the BRCA test. You can see that in the general population and in individuals who are identified with BRCA1 or BRCA2 mutations, the risk proportion, the numbers are significantly high. Okay, so when we are looking at a breast cancer, for example, is just 12% in the general population, 30% in the Indian population, but that can go to as high as 87% in an individual with a BRCA mutation. So that is why these individuals definitely need a very, very special protocol to be followed for their management in the future. So how do we manage these individuals who are identified with a BRCA mutation? For women, you have a breast cancer screening. They can be advised a monthly self-breast examination, a 6-monthly clinical breast examination, and an annual breast MRI. For the ovarian cancer patients, transvaginal ultrasonography and CA125, although this is just an option which is discussed in case they're very reluctant to the surgery, but they should very, very strongly be advised to undergo the surgery, because we all know that unfortunately the modes of screening that we have for ovarian cancer are not very effective. So for the males, they're at risk of male breast cancers and prostate cancers majorly. So a self-breast examination, they more than a self-breast examination, they need awareness and education about it, because it is something that is absolutely not known to the layman. And then you have the prostate cancer screening. Moving on, I think we've spoken a lot about BRCA today, so let's give a little more importance to the other genes which could have as much as an impact as BRCA actually, but they're not very well known about. One of them is Lynch syndrome. I think Dr. Kshitij explained a case to us wherein 2 individuals of a family were diagnosed with colon cancers. So in Lynch syndrome, we basically have 4 genes involved, which is MLH1, MSH2, MSH6, and PMS2. There's a new finding now that an EPCAM deletion also can cause Lynch syndrome. So with a very clinical approach, I would like to emphasize on the importance of MSI testing, microsatellite instability testing here. If you have an individual with a colorectal cancer or an endometrial cancer, especially at early ages, you should definitely recommend a micro instability testing. Basically, what happens with an MSI test is we are able to identify if these 4 genes are working fine on the tumor sample. If they're working fine on the tumor sample, I think we're good to go. In case there is any kind of missing deletion protein that we see on the tumor sample, the immediate conclusion is that like it's not seen on the tumor, maybe it's missing on the blood, and the direct correlation is that maybe the gene is not functioning properly. That's why the tumor is not being seen properly on the, that's why the protein is not being seen properly on the tumor. So an MSI test is very important. As soon as you have an MSI high, microsatellite instability high report on your MSI, the next indication should be a genetic test for these genes. So they could be at a risk of colorectal cancers, endometrial cancers, gastric cancers, ovarian cancers. Although gastric and ovarian cancers, the incidence is very less. The risk figures for them are very less, but the first 2 need to majorly be focused on. The next one is the Lymph syndrome. This, I think, again, it's even less popular than the Lynch syndrome. Although we all know the big devil behind it very well, it's the TP53 gene. So I think most oncologists, when they send an NGS panel, the TP53 gene is something which definitely comes mutated in all of them. That's precisely because the TP53 gene is known as the guardian of the genome. So any tumor that is occurring will definitely have something to do with the TP53, and that's why it shows as defected or mutated on your NGS reports. So because this is the guardian of the gene, the spectrum which the TP53 can cause in case it is mutated in the bloodline is very vast. Okay, so they can have a lot of cancers that can be included in this, majorly adrenocortical carcinomas, breast cancers, tumors related to the CNS system, osteosarcomas, or soft tissue sarcomas. Although the list goes on, there is no limit to this. There is no cancer which cannot be there in a TP53 mutation. That's why this one needs to be taken very seriously. And the management for this can be very, very aggressive, and it can be really hard on the patient because there are a lot of tests that we need to cover for them. The last one here is familial adenomatoss polyposis, which might present like a colorectal cancer only, but the only differentiating factor that you see here, that along with a colorectal cancer, the individual will have more than 1,000 adenomatoss polyps. So polyps in the colon, but they have not turned into a cancer yet. Although that's like a very, very big risk for the individual, because any of these adenomatoss polyps can become a colon cancer in the future. So if you have an individual with such kind of an history who has colonic polyps along with a colorectal cancer, they could be a very ideal candidate for the APC gene test, which basically diagnoses with them with a familial adenomatoss polyposis. Again, if you see in the third pointer, there are a large number of cancers which can be present in this one as well, but the major presentation for this would be polyps in the colon. So how exactly is a genetic counselor going to be helpful? What are the benefits that we can derive out of genetic testing and genetic counseling? So like Dr. Kshitij again, made this bifurcation very easy for me in his lecture. For affected individuals, what are the benefits that we can give them? We can help them make treatment decisions. We can help them decide what kind of treatment can be the best suited for them. Oncologists can change their treatment strategies based on their genetic test status. They can be given prevention or early detection for other cancers which could follow in the future. And there can be predictive testing which can be done for the family members. For absolutely healthy individuals, which probably would be family members of these individuals who have come to us first, For them, we can do a surveillance for early detection, prophylactic surgeries. We spoke about Angelina Jolie and the step that she's taken. So there are prophylactic surgeries which they can undergo, and there are some chemopreventive measures also which the oncologist can discuss with them. This was a very, a very technical and a clinical approach to, what genetic tests can do to individuals and how we can help them. Although a very, very big benefit that we provide to them as genetic counselors is to help them deal with the psychosocial issues which could follow with the genetic test. So a mother who's been diagnosed with a BRCA positive status, it is very difficult for a daughter to actually convey to her mother that maybe she is also BRCA positive. The mother has seen the cancer so up close that obviously she does not want anyone in her family to, get anything of that sort, even close to anything, get anything even close to it. So, but knowing that the daughter is at an 85% risk of a breast cancer post her can definitely be a very, very big trauma to the mother. So helping them deal with such issues, helping them cope with this, helping them accept things is something that a genetic counselor can help them with. Like Dr. Rushin actually caught my attention when he introduced all of us in the beginning, that the fear is actually of the unknown. So when something is not known, that's when the fear is bigger. When we help patients understand what their risk figures are, how much risk are they at, and what can they actually do to maybe reduce their risk figures? Are there any preventive measures that they can take? I think year by year, as they come closer and as they get more acquainted to this management, I think it becomes very easy for them to try and deal with this risk. So genetic testing, genetic counseling is something that should definitely be recommended, especially in cases of early cancers and in families with a very strong family history of cancers. Thank you very much.
So Dr. Divya, hello. So Dr. Divya has hit the nail. See, Udip, I was correct about reverse inheritance. Look at her. And you have made it so nice because genetics and familial and all these words are alpha, beta, gamma, theta for most of us. And she has nicely explained, and I think a lot of carry-on messages for us that we can explain to our patients and why these other immunohistochemistries, genetic testing, and all other things are very, very important for a proper diagnosis of a cancer, and then it can drive us to a proper treatment of the patient. With that, we are coming to the climax of the today's program, and none other than Dr. Vashish Manyar. And we have Dr. Bharat Bhatt, the president of General Practitioner Association, with us. He is going to be introducing Dr. Manyar. Dr. Bharat Bhatt, please. And before he comes to the dais, I have to make one nice announcement about D World Medical Association. They have arranged free vaccinations at Jain Clinic Hospital. So you can tell your patients if they can go to Jain Clinic Hospital for free corona vaccination.
Good morning, everybody. Well, I've been given this task to introduce Dr. Vasisht Pankaj Manyar. But before I enter over here, Vasisht straightway has performed a neoadjuvant therapy on me, and he straightway said that you better be very brief in my introduction. So, and whenever I hear this word brief, sorry, I'm always known to make it light. We had a professor of physiology, and he always used to tell us that short notes are like undergarments. They should be long enough to cover the essential parts and short enough to arouse the interest. So anyway, I will be very brief. Thank you, thank you. I mean, this credit goes to my professor, Dr. G.V. Bhatt, who incidentally became a dean of KM Hospital also. But this, he always used to say that, please don't keep me in fundraising committee, always keep me in fundraising committee. Okay, So now, sorry, so it's going to be very obvious how I'm going to talk about our sister. He has done his DM. Now, wherever a person has done DM, it's very obvious that he has done his MD, MBBS. And then I can say he has done his inter-science also, SSC also. But anyway, so just to cut it short, basically it looks from his biodata that he is a hemato-oncologist, and I would put it right from pediatric to geriatric. So these are his words, from birth certificate to death certificate. So now may I invite Dr. Vasishtha Maniar to brief us.
Thank you so much, Dr. Bhatt. And genuinely, it's been a very interesting morning. At the offset, I would want to thank Dr. Anil Mehta sir, Dr. Kamlesh sir, and the entire association for having us on a Sunday morning. Sunday morning, our back is how I would want to, take this up. Last 2 years, we've been sitting lazily at home, waiting for our internet browser to open and see these meetings from the comfort of our phone. So the way we are very excited that our children are going back to offline schools, I'm sure our family members are also very excited that all these spouses are back to the IMA hall on Sunday morning and they have a morning to relax. Today is unfortunately a sad day for India, I would say, because the Nightingale of India, Shri Lata Mangeshkar Didi, is no more with us. And with the permission of the chair, I would request if we can spend 30 seconds in remembering her, because she is the reason why many of us have gotten up in the morning or have slept, and she truly is the voice of India. So this is in remembrance and respect of Lata Didi. So we may. So we come to the fag end of today's discussion. And since we are talking about reverse inheritance, as Anil Mehta sir has very beautifully put it, this is actually a reverse lecture as well, because the last lecture that we spoke about was cutting edge genetics, cutting edge tech. How can you prevent cancers? How can you predict the human genomic behavior? This lecture is, in my opinion, comparatively very primitive, because I call this a Saturday night or a Monday morning lecture. We call this the holy grail in cancer diagnosis. Nowadays, with WhatsApp, mobile phones, unfortunately, the family physician never gets a break. So 24/7, you are expected to reply to your WhatsApp messages. Sunday evening, you want to relax, and suddenly your old patient of 40 years has shooted you something on WhatsApp. So can we try and understand and grade these WhatsApp messages of what need to be replied on a Saturday morning, or what need to be probably told to take over, take the weekend off and see me on Monday in my OPD? Can we create a triage for these, and especially when it comes to cancer? And hence, I actually have named this talk as the Holy Grail in cancer diagnosis. What is the Holy Grail? Holy Grail is something that all of us want, but it is very hard to get or achieve. It was said to be the cup that Jesus Christ had with him, and it was sought by the knights during the Middle Ages. So thousands of years and thousands of battles have been fought to get the Holy Grail. And why do I mention that as in parallels to cancer diagnosis? Because unfortunately, unlike majority of the diseases now, which has a single simple diagnostic test. For example, if you have a chest pain and you do an ECG, you have a diagnosis. You do a coronary angiography and you have a diagnosis. You do a stress test and you can document ischemia. Somebody is having fever with chills, you do a malaria antigen, it is positive, it is diagnostic. Is there one single simple test which can diagnose cancer? The answer is no. Whenever, as Rushin beautifully put it, that 48 hours of anxiety is because from the time that your general practitioner tells you that, look, I could be looking at cancer as a differential diagnosis,
till the patient is actually initiated on therapy, there is tremendous amount of anxiety, tremendous amount of apprehension, and there is no single predictive test. You know, after today's Divya's lecture, suddenly some of us sitting here would remember that my mother had breast cancer, 10 years back. And where does that put me? So can I do one single predictive test today, like a swab for an RT-PCR for COVID, and find out whether I can develop breast cancer or not? The answer is no. Is there a single definitive test to diagnose cancer in general? Again, the answer is no. Do we need a biopsy to diagnose every cancer that we have thought of? Again, the answer is no. So how do we approach cancer diagnosis? Let us try and talk about Dr. Desai. I'm assuming one of us could be Dr. Desai sitting here. Dr. Desai has had a very busy week. Today is Saturday evening. He has planned, finally the theaters have opened. So his family have planned to go and watch Kapil Dev's 83 movie, which he had live seen 30 years back, and Romani's the all beautiful victory that we eventually went through. Suddenly he gets a call from a patient's daughter. Now this young lady has been treated by Dr. Desai when she was 5 years old. She's recently delivered. Dr. Desai has also eaten the sweets of her delivery when she was delivered. Now she says that she is 4 weeks postpartum. And while breastfeeding, she has noticed a lump, which was 4 by 3 centimeters. It is tender. It is in the right upper outer quadrant. The skin over the lump is feeling very inflamed. So what did she do? She Googled. And Google says that this is pure the orange, which is a stage 3 breast cancer. And now she sent a very dingy photo of an infiltrative, inflamed, small lesion in the upper quadrant of the breast. What should Dr. Desai do? Should Dr. Desai switch off his phone and go and enjoy 83 movie? Should he cancel his movie and ask the girl to come and see? This is a big, big dilemma, because if he cancels the movie, he has to face an angry wife. If he switches off the phone, he has to face an angry patient. What should we do? So can we help and create a consensus on these situations which we probably face every day in our lives? Now, there are 2 or 3 differentials when it comes to having a single tender lump in the breast. If it's a single tender lump, what I believe Dr. Desai should do, this could be nothing but an inflamed mammary cyst, which is very, very common that you see in postmenopausal women. So Dr. Desai should tell her that why don't you take a course of antibiotics. Now the problem with antibiotics is the fact that she's breastfeeding. So we'll have to give her antibiotics which can be given in postpartum era. So you can use maybe an early generation cephalosporin or an augmentin, give her local hot fomentation and allay her anxiety. But importantly, Dr. Desai should insist that you take this antibiotics for the next 3 days. At the end of 3 days, if you are not better, do come and see me on Tuesday morning. Why? Because a percentage of these patients would actually be suffering from a very aggressive variant of breast cancer called as inflammatory breast cancer. Inflammatory breast cancers are triple negative. In Dr. Seema's language, they do not express ER, PR, and HER2, and they have a very aggressive outlook. So we should not just relax and tell them take the antibiotic, it's going to die, it's natural death. Keep a very close follow-up, and if at the end of 3 or 4 days, the pain is not reducing, the swelling is not reducing, get at least a breast ultrasound done and also a mammography if the symptoms do not reduce. So do not ignore an inflamed breast lesion. All breast cancers need not be painless, is the message. But yes, of course, Dr. Desai should go and watch that movie on Saturday. Case number 2. Case number 2, we have a 48-year-old gentleman. He says that typically every day morning, he goes for a walk. For the last 15 years, he's been going and walking 4 kilometers at Nariman Point. But for the last 3 weeks, every 800 to 900 meters, he feels slightly tired. Investigations have been done, and he's, I think, I'm stepping on some wires. Yeah. Yeah. Investigations have been done and he is found to have anemia. His hemoglobin is around 8.5 and he Googled and did a CT scan. He did a CT abdomen plus pelvis, which was plain. And the report mentioned that there are a couple of lesions seen in the liver. There is a 2 by 2 centimeter lesion in segment 4 and another 2.1 by 1.1 centimeter lesion in segment 5, and they could be malignant. And the next Google also gave him an answer कि अभी इसका biopsy करा लो. Get a CT carried biopsy done by the radiologist, and the patient has already booked an appointment for a biopsy. And then he suddenly remembers that he has a family physician for the last 30 years. So he calls up the family physician. That, you know, doctor, kal mera biopsy hai, you are okay with it. What should the family physician do? Why don't we help Dr. Kale? Now, Dr. Kale is in the conundrum that he says, should he go ahead with the biopsy? Or should Dr. Kale say, no, don't do the biopsy. First come and see. Let's investigate. Let us not forget, medicine was never about investigations. It was always about clinical judgments, and investigations were always meant to enhance your repertoire of diagnosis and the right sequence of investigations. It is not uncommon, even in our practice, where patients come up with a PET scan report without even having bothered to get their basic investigations or symptoms addressed by their family physicians. And now with the availability of investigations more and more, where people can book an online PET scan via an app, it's not going to be uncommon that you have a patient who has a PET scan report without any other investigations done. So we'll have to actually reinvent the wheel of diagnosis from history taking to examination. So let's not forget, how we started as clinicians. So what should Dr. Kale do? In my opinion, Dr. Kale should say, wait, don't get this biopsy done. First come and see me. Understand, why would a 48-year-old male have a blood loss anemia? Is he iron deficient? Very unlikely for somebody who's physically so active. So when you have blood loss anemia, and that too in a male, we should look at the GI tract. There is a strong chance that he could be suffering from an upper GI or a lower GI bleed. So the next question that Dr. Kale should ask his patient is that, are you suffering from any upper GI symptoms like persistent retching, abdominal discomfort? You feel full after having very little meals? If he says yes, these could be pointing towards an upper GI malignancy. So the next investigation should not be a CT carried biopsy, but rather an upper GI scopy to document any lesion. If the symptoms predominantly are alteration in the bowel habits, persistent loose motions, initially for 20 years he's been passing one stool at 6 a.m. Suddenly he says that he's constipated twice a week, he has diarrhea twice a week, and all of us have a very beautiful habit of justifying our symptoms. Last 2 weeks I've been eating out very often, but he's been eating out for the last 30 years. These symptoms are acute and they do not want to be addressed. So picking up this clinical pearls of recent alteration in the GI habit, dark tarry stools, having persistent constipation, change in the way you perceive your food habits are all symptoms of GI malignancy. Because what is going to happen is when you do a biopsy, a CT carried biopsy from the liver, all it is going to mention it's an adenocarcinoma. And then you will still have to end up doing a GI scopy, lower GI scopy to achieve a diagnosis. So why go the ulta way? Let's do a typical upper GI or a lower GI scopy, look for a primary, and then should be the next investigation. So let's assume that this patient finally had some sense and met Dr. Kale. Dr. Kale insisted on first a colonoscopy. And the colonoscopy now says that there is a lesion in the cecum. And the biopsy of that is an adenocarcinoma. What should be the next investigation? Should this patient undergo an emergency surgery? Again, the answer is no. Because this patient, remember, had 2 lesions which were seen on the CT scan. Another important fact here is that the CT scan which was done was a plain scan. It was not a contrast. So whenever we are suspecting a GI malignancy, insist on both oral as well as IV contrast. So the next step for this patient should ideally be a colonoscopic guided biopsy. If it confirms adenocarcinoma, it should be a fresh CT scan with oral plus IV contrast to delineate the anatomy of the tumor. And that should be followed up with a PET CT scan to understand if you are looking at disease outside this area as well. Prima facie, this looks like a stage 4 cancer because you have colon malignancy and 2 lesions in the liver. Is that really very bad? Is that the end of the road? Should you start counseling about end of life? No. Stage 4 colon cancers, even with liver metastasis, can potentially be cured. About 1 in 5 of this will be alive at the end of 5 years with the newer advances of chemotherapy, targeted therapy, and targeted radiofrequency ablation of the liver metastasis. So even if you see a metastatic colon cancer, don't give up, because if this patient comes to you even with the entire ambit of diagnosis, I have seen this in the past where a patient has been told that he has stage 4 colon cancer, and by stage 4 he has 2 metastases in the liver. Okay. He has 2 metastases in the liver. Saturday evening he went to his general practitioner. His general practitioner said, you know what, you have stage 4 cancer. And by the time they meet a medical oncologist or a surgical oncologist on Monday, they have practically given up on life. Please remember, a good number of these newer therapies have dramatically changed the way that we look at advanced cancers also. In fact, the one person sitting next to you in an auditorium, in a movie could be suffering from stage 4 lung cancer for the last 5 years, and he or she could be eating a small tablet. Now with these newer medicines that Dr. Shima mentioned about, you could have a metastatic breast cancer who's been on treatment for 5 years, and this person could be your neighbor. This person could be your doctor. Your doctor who's treating you could be suffering from metastatic breast cancer and still be taking a palbociclib and a letrozole for the last 5 years and continue to operate probably 16 hours a day. So we have come from a very, very long way where everybody who had cancer is meant to die immediately to people who live a beautiful quality life, reasonably asymptomatically continue to dispense their basic duties towards themselves and their families. And most patients, most people around don't even know that they're suffering from cancer. So after Dr. Kale, we'll have to help somebody else. Can I go to my next slide, please? Yeah.
Okay.
So we've helped Dr. Kale, and we'll now go to the next doctor, who I thought is Dr. Sanghvi, but presentation seems to have hanged. Okay. So next is case number 3. Again, a clinical conundrum that we see very, very often in our practice. A 54-year-old male, HCV positive. He's a high flyer. He's a managing director of one of the newer multinational companies. He's been a cirrhotic for the last 10 years. He's been on a very, very strict follow-up with his gastroenterologist, who has been doing his alpha-fetoprotein every few weeks. He undergoes a recent investigation which reveals that his AFP has increased from 4.8 to 28. Now, this gentleman, because he's been in regular touch with his gastroenterologist, has not bothered to meet his family physician in the last 5 to 10 years. And this HCV positive cirrhosis was diagnosed by this family physician. But now, because the gastroenterologist is available, he's been in constant touch with him and without bothering to inform his family physician of what has been happening over the last 10 years. He undergoes a sonography, and the sonography says that there is a nodular liver, which is same as before. It was the same 6 months back, and it is the same now. And he visits Dr. Sanghvi, who is his family physician for the last 30 years. And who says that, you know what, doc, my AFP has increased. Why don't you call up my gastroenterologist? I don't seem to get him now. His phone is not available. And he suddenly realizes that the gastroenterologist is gone to Himalayas for a 10-day trek and is not available. So back to family physician, who has not seen the patient in the last 10 years. What does this patient and the family physician do? The family physician says that I do not know what has happened to you for the last 10 years. And the gastroenterologist who's been looking after him every few months is not available. What should the patient wait for the next 10-15 days for his next set of investigation? Can we advise him on any one specific investigation that can help him? Typically, the patient says, you know, doc, I have gone online and I think I need a PET scan because my AFP has risen. Should I just give him a prescription for a PET scan so that, you know, I don't have to answer more questions? The answer is no. Because if you are HCV positive and you are cirrhotic and your AFP is rising, there is a strong chance that he has now developed an hepatocellular carcinoma. And a hepatocellular carcinoma may not be picked up on a PET scan. The best investigation for this patient is a triple phase CT scan, because when you have a cirrhosis, you have a lot of regenerating nodules, and a triple phase CT is going to pick up what is called as venous washout, which is a very classical feature of HCC. So all the family physician, Dr. Sanghvi, has to advise, and very confidently so, that you don't need a PET scan, you don't need an MRI. All you need is a triple phase CT scan. Very likely that the triple phase CT scan will tell you that in one of these nodules, you are seeing about, say, a 2 to 2.5 centimeter small lesion, which looks malignant. What should be the next step? CT scan तो आपने ट्यूसडे को बोला, शाम को रिपोर्ट आ गया, गैस्ट्रोएंटरोलॉजिस्ट बैठा है हरिद्वार में भगवान का नाम लेने के लिए, and the patient has already WhatsApped you the report before he comes to you, and he says that, you know what, doctor, I think I should get a biopsy done. So should we just give him a prescription over WhatsApp for a biopsy? The answer is no again. HCC is one of those diagnoses which can be made over a CT scan. It is one of those malignancies which do not require a biopsy. A triple phase CT scan with a classic venous washout is enough to diagnose HCC, and you do not need to biopsy these lesions. So you can tell your patient very confidently that no, since the scan mentions that it looks like an HCC, you do not need a biopsy to confirm it. Yes, either we can wait for the gastroenterologist to come for the next 1 week, or this patient can now go to a medical oncologist or an interventional radiologist or a surgeon. For early stage HCC, the curative intent treatment would be either a surgical excision if the residual liver is good enough, or a transarterial chemoembolization or radioembolization, which is done by an interventional radiologist. So this patient does not need a biopsy. This patient does not need a PET scan. We'll go to the next case, which is a 43. Yes, sir. Somebody had a question? No, okay. Dr. Bhatt just advised a biopsy to somebody on his phone. So we have a 43-year-old male. He's been having dyspepsia for the last 3 years. Finally, he undergoes an endoscopy. His family physician, Dr. Khan, is now tired. Every time he just gets his antacids changed, and he says for an endoscopy, the patient runs away. Sir, वो pipe नहीं डलवाना है मुझे. आप दवाई अच्छा लिख के दे दो. And Dr. Khan has no option but to change the antacid or increase the dose and let him be. Finally, after 3 years, he undergoes an endoscopy and is found to have a submucosal lesion, and that was biopsy. The biopsy of this is a neuroendocrine tumor with an MIB index of 1 to 2%. And this patient has already Googled everything about it. He is now worried that he has got a brain cancer which is there in his stomach, which has spread. And he starts panicking and calling Dr. Khan that there is 20 patients waiting outside Dr. Khan's OPD. But he says that, you know what, I have a very aggressive cancer. You have to not make me wait, and I need urgent treatment. And what do I do? What should Dr. Khan do? Should he just cancel his OPD and let him in? Or can Dr. Khan tell him, kuch nahi hai, 2 din ke baad aana? This is one of the most indolent or slow forming types of cancers. Dr. Khan can tell him 4 din ke baad aao, because these tumors are extremely slow growing. They are called as neuroendocrine tumors, which are very, very commonly found in the stomach. And the treatment for such is just an endoscopic ultrasound guided excision. Most patients, unfortunately, in the last 10 years that I've seen, they have met their general surgeons, and some have been advised radical gastrectomies. They are locally recurrent tumors. You do not need major heroic surgeries. Just an endoscopic excision of that tumor is enough. Yes, these patients need to be put on close surveillance. Anybody who has long-standing acidity or gastritis can be suffering from what is called as chronic active gastritis. These patients who have chronic active gastritis are at a high risk of developing neuroendocrine tumors, which are very, very slow-growing tumors. And the only treatment that they need is a wide local excision, can be done endoscopically. Does this patient need a PET scan? The answer is no. However, if on the endoscopy this was a large tumor, 8 centimeters, 10 centimeters, and you do a sonography and it shows liver metastasis, do you need a PET scan? The answer is again no, because these are what we call as NETs. And for NETs, we do not advise PET scan. We advise what is called as a DOTA tox scan, because they are functioning tumors. And these are different types of scans that we use and not the routine PET scans. So remember, whenever you have a low grade NET, do not advise a PET scan. Advise a DOTA PET scan or a DOTA scan. I'll go to the last case, the second last case rather, if you have the time. A 62-year-old female, abdominal distension and pain since a few weeks, CT abdomen done, shows bilateral adnexal masses, gross ascites, peritoneal thickening. 2 times ascitic fluid has been tagged, cytology is negative, BACTEC is negative, MGIT is negative. Typically, all the non-malignant workup is negative. The CA125 is 200, it is not significantly elevated. The CEA is 12, again slightly elevated. The CA 19.9 is 116, again slightly elevated. So none of these tumor markers are diagnostic for somebody who has such extensive amount of disease. The family visits Dr. Thakur, who is a routine family physician, and there is no clarity as what should be the next road ahead. This patient then undergoes an upper GI scopy and colonoscopy, because after listening to Dr. Udiv's lecture today, everybody has a better idea कि भाई एक बार endoscopy करा लो, उधर कुछ मिल जाता है. Unfortunately, they are also negative. Now this patient undergoes a biopsy, and the biopsy says that it is adenocarcinoma of unknown origin. It could be primary ovary, it could be primary peritoneum. And what should be the next step be? These are pseudomyxoma peritonei tumors. When you have not very high markers in terms of the ovarian primary or the colon primary, and the endoscopy and colonoscopy is negative, these are primary peritoneal carcinomatosis which have arisen from the peritoneum. Remember, peritoneum is now an organ, and the best treatment for such patients is upfront surgery whenever it is feasible. If not, these should be treated like ovarian cancers. So 3 cycles of neoadjuvant chemotherapy, downsize the tumor, and then go for adjuvant intent chemotherapy. Last but not the least, again a Saturday night case. This time Dr. Mehta sir is about to finish his OPD, I think at 11 o'clock in the night, sir? Unfortunately, yes. And he's very tired. He's seen a lot of patients, wants to have his Sunday morning CME planned with 500 doctors. And then there is a new patient who walks in. This patient is an IT tech guy. He's just come from Bangalore to Bombay. He's visited 3 general practitioners. He does not have a fixed family physician because he's been having persistent low-grade fever for the last 15-20 days. He says that he feels tired enough. He wants to switch off his video when he's on an online meeting. Nowadays, everybody's definition of fatigue is different. 5 years back, definition of fatigue was कि पहले मैं 5 किलोमीटर चलता था, अभी 1 किलोमीटर चलता हूँ. Today's definition of fatigue is कि I don't feel like switching on my video, on my online work atmosphere. He's already undergone a CBC, urine routine, SGPT, Vidal, creatinine, X-ray, and sonography, and he comes with these battery of investigations, Dr. Mehta. Now, what are the investigations and how do they look like? His hemoglobin is 12.2. His counts are 19,880. No doubt he's received about 3 different antibiotics, each for 5 days course with no improvement. He predominantly has a neutrophilic leukocytosis, and hence all of the family physicians were contemplating that this could be an infection. His Vidal was also positive. So he again hence received all these antibiotics. His SGPT is mildly elevated, which is 51. His creatinine is normal, 0.8. The X-ray is normal. Sonography shows a mild splenomegaly. What should be the next investigation that Dr. Mehta should think of? It's already Saturday evening. Should we just give him 1 more antibiotic and tell him 5 din ke baad aao? Most likely, if Dr. Mehta does that, this patient will land up on a 5th general practitioner's clinic on the next Saturday after completing his 5 days antibiotic course. The one thing which is very fishy in this report is basophils. which are about 6%. So I believe Dr. Mehta should think he's been taking antibiotics for the last 3 weeks. This Vidal could be false positive. He predominantly has a persistent neutrophilic leukocytosis. He has a mild spleen and he has a basophil count of 6%. This could be a chronic myeloproliferative disease. This could be CML. This is how CML can now present. Gone are the days that we were reading in our textbook that people will present with massive spleens crossing the umbilicus, people presenting with 2 lakh counts, 3 lakh counts, because that's not the patient that we see in our clinical practice. The ones that we see are people who have 15,000 counts, 19,000 counts, have received 3 different antibiotics. They're still not getting better. They're restless. Somebody would advise them admission. Now we'll give you IV antibiotics. How the heck your counts are not coming down? Because this is not an infection-driven leukocytosis. This is most probably a myeloproliferative-driven leukocytosis. 2 tests that I would ask Dr. Mehta to do when he's seeing this patient on a Saturday night is to do what is called as a JAK2 mutation, that is JAK2V617F, and do a BCR-ABL. This rules out that is CML, chronic myeloid leukemia, and broadly chronic myeloproliferative neoplasms. And don't be surprised if these investigations are positive when they come and meet Dr. Mehta on Tuesday or Wednesday. The next investigation will be a bone marrow aspiration and biopsy, and the treatment is again going to be 1 tablet. And you will see in 7 days the CVC becomes normal. So we've done again what is called as reverse engineering, where from genomics we've come to Saturday night and Monday morning clinics. And I think the theme of today's talk was very beautifully set up by Rushin, and that is the fear of unknown. And oncology, unfortunately, is always about the fear of unknown. And as primary caregivers, can we address this fear of unknown by instilling science, logic, with a lot of compassion to ensure that our patients are carried on in their journey of being diagnosed and treated well, and most of them early stage can now be cured also. Thank you. Thank you so much. The forum is open to questions and answers. And I think most of us are here, so you can ask questions to any of the consultants that you wish. Yes, sir, of course, please. What is? Lymph-breast therapy. So lymph-breast therapy is typically done in people who have undergone breast cancer surgery. And post the breast cancer surgery, because they've undergone what is called as an axillary lymph node dissection, there is a secondary lymphedema of the tissue. So the hand is swollen. Lymph-breast is a machine wherein you wear a sleeve and it does a lymphatic massage and hence reduces the secondary lymphedema post a breast cancer surgery. It is often seen in ovarian and endometrial cancer patients post a surgery where they get lymphedema of the lower limb as well. So the cost of scalp cooling machine is very expensive. Per therapy, the rates are about 3,000 to 5,000 rupees per session. And yes, sir, it is covered in insurance. Yes, sir, please. What is? FAPI PET scan. I am hearing this for the first time. There is something called as FDG PET, which is fluorodeoxyglucose, which is typically done for all solid malignancies. The other variations of FDG PET are a PSMA PET, which is typically done for prostate cancer. Then there is a DOTA PET, DOTA, which is done for neuroendocrine tumors. So these are the most 3 common PET scans that we do across all malignancies. I have no idea, sir. That must be a functional scan, sir, but I believe it does not have any diagnostic or therapeutic relevance in a day-to-day clinical practice. And I would want to believe, sir, if I don't know, it probably may not be very relevant. So a PET CT, so we have to understand that when we talk about a PET CT, we're actually amalgamating 2 different modalities of therapy. A CT is, an anatomical scan, and an FDG PET is a biochemical scan. So you're trying to merge anatomy, biochemistry, and physiology together. When we offer somebody a PET CT scan, usually the concomitant CT which is done along with the PET may not be of great quality. So when you're looking at soft tissue masses, people would want to prefer a PET MRI because MRI has better local anatomical delineation than a CT scan and hence a PET MRI. Again, very, very honestly, if you ask me to put a hand on my heart, is this something which is dramatically path-breaking and is it going to Monday morning change our practice? The answer is no. And as the point of my entire talk was, it's a fallacy that everybody who has cancer needs a PET scan. It's very, very essential to understand the anatomy of the disease, the physiology of the disease, the biochemical behavior of the disease. Because what happens is sometimes, before somebody has undergone a biopsy, you advise a PET scan, and then somebody else tells this patient that you never needed a PET scan. And the message is very, very wrong, where the message that we had was an eagerness to come to a better anatomical delineation of the disease. People would comment that we've been too hasty in advising investigations. And hence, reinventing the way we learn medicine probably is the way we should practice medicine and also advise investigations. And we should take our patients into confidence, that this is how it should be done. Even if they are bombarded with new Google information, WhatsApp knowledge, sometimes I've seen, even with us, as medical oncologists, the patient dictates what should be the next investigation. And sir, I think we should put our foot down, because if we are actually giving into their anxieties, we are not doing the right thing. Our job as physicians is to tell them what is right and what is wrong, and let them be at the fear of keeping them unhappy, because they may be transiently unhappy, but in the long run, they've realized that you've given them the right advice. Yes, sir.
The financially compromised patient.
Sorry, sir. Yes.
To help the financially compromised patients.
So, sir, we run a foundation called as MOC Cancer Care Foundation, which is predominantly made out of the MOC company. So, MOC is actually a group of about 18 medical oncologists who are currently practicing across 7 centers in Bombay and in 3 more cities. We will have about 16 centers across Maharashtra and Madhya Pradesh by the end of next 3 months. And using our own pool and a lot of generous donors as well, we have created a Section 8 company, which is called as MOC Cancer Care Foundation. And anybody who deserves help is helped to the tune of about even 80%. So if there is a therapy which costs, say, 10 rupees, 80% of that burden or 8 rupees of that treatment burden can be absorbed by the foundation. So anybody who is financially feeble, we would love to help. And this help is extended irrespective of where the patient takes treatment. So if this patient is not taking treatment at MOC, still the patient is eligible for that benefit. You could be having a patient be treated by XYZ doctor in XYZ hospital. And if you feel that this patient deserves therapy, please send it to us. We have financial counselors at most MOC centers. And I can assure you that these patients will not be told to change their physician. And we will insist that whatever best financial help can be provided will be provided. Yes, I'm sorry, sir. Please come again, sir.
Generic medicine and the regular medicine.
So this is actually a Pandora's box. When you open the difference between a generic and a regular medicine. How I answer this question, sir, is I ask myself that if my relative has this cancer, am I comfortable giving this drug to my relative? And if my answer is yes, the answer to my patient is also yes. To simplify this answer further, what I would believe that generic is not one company. Generic can range from a standard Indian multinational like Intas, Cipla, Zydus to a company which you and me have never heard of. So my rule of thumb when it comes to generic is, if I have heard of that company in my practice over the last 15 years, I say yes to my patient. If I have not heard of that company, I say no to the patient. Yes, of course, madam. So BRCA test is available at MOC and across all the centers, but I think the cost may vary from about 15,000 to as much as 1.5 lakhs. And I will actually request Dr. Divya to explain why. And this again is opening up a new Pandora's box here, because BRCA test can happen at SRL also, and it can happen in American lab also. So what are the different types in which BRCA can be found out? What is MPLA? What is NGS? I request Dr. Divya to take that question.
So the BRCA test basically first happens with the tumor sample and the blood sample. When you're doing it in the tumor sample, the whole idea of getting the testing done is to understand if there are any further treatment strategies that you can use for the patient. When you're doing it on the blood sample, predominantly we're trying to understand if there is any inherited BRCA aspect that we're trying to look at. Again, in the BRCA gene, you can have two types of changes. You can have small changes and you can have big, large variations, which we basically call large deletions or duplications. Most of the sequencing tests, most of the tests that people would pitch in as a BRCA test involves looking at only the small variations. Although this is pretty much helpful for the patient because majorly you have small variations which comprise in the BRCA gene. But we need to remember that it's a 70-30 ratio. So even if we have a negative sequencing test which comes back, there is still a 30% probability that maybe there could be a large deletion. Get an MLPA test to be able to tell the patient 100% that it's a BRCA negative. Again, when Dr. Vashish mentioned about the high-end tests, mostly the ones which go up to 1.5 lakhs are the tests which happen on your tumor samples, which will majorly include a lot more genes other than the BRCA, which fall in the same pathway as the BRCA gene. Basically, if you have mutations in these genes, it's not a direct mutation in the BRCA, but it can indirectly affect the function of the BRCA gene. So you have a lot of panels which have come in now, which basically helps us look at genetics with a broader perspective at a cost-effective way. Okay, so understanding it's very important, ideally, to order these tests based on the history of the patient. If you think it's very much a BRCA kind of an history which you're looking at, then a BRCA sequencing and an MLPA test should be more than enough. But then if there are like variety of cancers which you're seeing at very different ages, maybe a panel would be a better suited test for this individual. Oncotype DX again is a test.
So Oncotype DX is a test which is done in a specific subset of hormone receptor positive. So you need to be ER and PR positive breast cancer. Your HER2 should be negative. The size of the tumor should be at least, it can be up to 5 centimeters. And you may or may not have up to 1 lymph node positive. So till recently, all breast cancer patients were given chemotherapy, irrespective of their behavior. Now we believe there are certain breast cancers which are called as lobular cancers, lobular A or luminal A, which Dr. Seema spoke about. Oncotype DX test is a test which identifies these lobular carcinomas using a complex AI and a multi-gene assay-based algorithm. It is done in the US. The sample can be collected from the patient's home, and the turnaround time is about 3 weeks, and it costs about 3 to 3.5 lakh rupees. What is the outcome of the test? The outcome of the test is when you send the tumor tissue for these particular subset of patients. I'll repeat, up to 5 centimeter size breast cancer, hormone positive, HER2 negative, and up to 1 to 2 lymph nodes. And there is a probability that they will fall in the low risk category of Oncotype DX, in which case they do not need or they will not benefit with chemotherapy, and they can just be given hormone therapy.
Just a follow-up question here. That if we decide that this patient may not require chemotherapy,
yes,
and if we give, so why it is important to know that the chemotherapy should be specific? In the sense that the chemotherapy has long-term effect on the parts of the body.
Absolutely, sir. So that's a very pertinent question, which we are asked very often in our practice. Okay, sir, this is an expensive test. उससे अच्छा आप थोड़ा chemotherapy दे दो. Now we have to understand that nothing in the world is free of side effects. I believe even drinking water has side effects. You have to go to the bathroom, right? So any therapy which is not indicated in a particular tumor type, why do we give chemotherapy? Because we want to prevent a recurrence. And by doing an oncotype, if you can document that this patient is not going to benefit with chemotherapy, and the benefit of chemotherapy in those patients is 0 or nil, less than 1%. So oncotype DXR actually gives you a score. And if the score is less than 26, say the score is 6, then you know that this patient is going to have practically 0 benefit with chemotherapy. Then are we justified in trying to, expose them to, even if they are temporary or even if there are long-term side effects of chemotherapy?
And we are nowadays we are seeing that a lot of people who go for their health checkup program, they do order tumor markers, any tumor markers of any tumor, and then they come with some variation.
Borderline.
So how do we respond to them?
Very, very important question, sir. Because now with new bundles of healthcare, where you get 100 tests done in 500 rupees, you get CA125 level done in male patients also, and testosterone done in female patients also. I've had patients who come with chromium levels and ask me the importance of it on Saturday evening, and I don't have an answer. So, sir, there again, let's follow science. And science is that there are certain markers which have high predictive and prognostic value, and there are certain others which don't have. So if you have a PSA which is high, it's important to not ignore it, assuming it was done in a male. Okay. If you have a CA125, which is again high, and this patient, so by high, I mean it is 40. Now normal limit is still 35. So what Anil sir is talking about is about a 45-year-old female who does her annual checkup, and her CA125 is 38 and the normal limit is 35, and she has decided that she has ovarian cancer and she wants to be the next Manisha Koirala. So she also undergoes a sonography. The sonography also is normal. These are the patients that you should do an HE4 level. It's again a blood test, and the ratio of HE4 to CA125 is going to have some predictive value in defining whether this patient needs further investigation like an MRI pelvis or not. So an isolated CA125, which is borderline normal, can be ignored for the time being if basic radiology is negative and if the CA125 HE4 ratio is also normal. Otherwise, PSA, very, very sacrosanct in males. Any tumor marker which is grossly elevated, a CEA should be about 5, is 40, cannot be ignored and should be investigated. Yes, sir, please.
What is immunofixation?
Immunofixation is a blood test which is done in people in whom you're suspecting a plasma cell disorder, multiple myeloma being one of them. It's a simple blood test where they actually break down the serum proteins and look at which are the different types of proteins. So you have albumin, you have globulin. Globulin would be alpha, beta, gamma. When you're suspecting myeloma, there is a paraproteinemia. That means there is a monoclonal M band which is seen in a serum protein electrophoresis, which is suggestive of a plasma cell dyscrasia. A very important corollary to that question, sir, is that whenever you see an M band, it does not necessarily mean myeloma. That's also a very important thing to know. It is the quantum of M band which is important. If you have a 0.1 gram M band, it may be what is called as MGUS, which is monoclonal gammopathy of unknown significance, which has only a 1% of risk of being converted into myeloma per annum. So every M band need not be multiple myeloma. Similarly, every M band need not be even a plasma cell disorder. You can have low-grade lymphomas which can secrete a small M band. So when you have an absolutely out of the blue small M band and your multiple myeloma markers are negative, search for a low-grade lymphoma by doing a generalized screening for lymphadenopathy. Any other questions or then? Yes, sir.
In HCC, does TheraSphere help?
Does what, sir?
TheraSphere help in HCC?
Yes, sir, it does help. It does help. So I believe, sir, now, so there has been a paradigm shift in how we have looked at HCC. About 10, 12 years back, sir, I remember the only job of a first year medical oncologist was if you have a multicentric HCC, tell them, Ghar jao. There was no treatment which was available. The only drug which was available was a tablet called sorafenib, and which was extremely toxic. Caused a lot of hand-foot syndrome, nausea, vomiting, diarrhea, fatigue, and with no significant improvement in the symptomatology. Now, with these newer loco-regional directed therapies like transarterial chemoembolization, transarterial radioembolization, there has been a significant improvement. Even the oral therapies have become so much more better. We had only sorafenib. Now there is lenvatinib, there is cabozantinib, there is immunotherapy, first line, second line. So HCC, which 10 years back had no treatment, where HCCA sent this patient to the first year and asked him to counsel. Now HCC is lapped up by the professor because he can offer 10 different types of therapy. And it's not uncommon to see a metastatic HCC live for years at end if they respond well to the right therapy. Great, thank you so much. I'll hand over the proceedings to Dr. Mehta sir, and thank you again for having us. Yes, so we'll follow this with lunch, and one of the reasons why we were keen to meet today was to inform that we have started a Chems Corner Center of MOC, which is there in Pan, Bombay. Now we've made our presence felt, which is at Shripati Arcade. And it will be great if post the lunch, it's about 400 meters from here. If you can drop in there and just bless us at the new center. Obviously, there is going to be an official proper opening once this Omicron completely goes away. But if you can today, since we are here, we've met, it's about 400 meters from here. And we'll happy to, just show you the place around, and we can have a cup of coffee there and have, sharing of some mementos also. Thank you so much, Nala.
Thank you. So we have started the series of cancer coverage. Now we should come out of the Omicron, hopefully. And we are starting the cancer coverage. The first of today, it is over. Fantastic, very well received, Dr. Maniyar and the team, and all the doctors, and especially I am quite impressed with my genetic specialist. Thank you very much for coming. Yeah. And I want Shima to say something.
Someone asked about FAPI PET scan. So I just read it on Medscape. Now there are various types of PET scans. The most commonly which is used is a FDG PET scan, in which the radioisotope used to localize the cancer cells is a FDG glucose. And other types of PET scan are PSMA PET scan, in which the PSMA is the tracer which is used for prostatic cancer and which is more sensitive for prostate cancers as compared to FDG. Third type of PET scan is a DOTA PET scan, which is used for neuroendocrine tumors because they secrete DOTA. So DOTA isotopes are picked up more in the neuroendocrine tumor cells. This FAPI PET scan is fibroblast activating protein inhibitor PET scan. It was used in preclinical studies and it is not used in clinical scenario. But now it is being validated in some centers. Fibroblast, it is protein inhibitor. It is used to localize those cancers which secrete this fibroblast activating protein like pancreatic cancer. This is an upcoming radioisotope which is being used in the PET. So we will have the knowledge about it in future, but still it is not validated and it is available only at very few centers. Apart from this, one of my patients, I want to share the information. The other day in the clinic, one homeopathic doctor came.
22 November 1963
about 48-year-old came to And then they just came to ask my opinion. They were now in history, they gave that both the twin brother, one is a homeopath doctor, other is non-medical. Both of them, they got operated on the same day by the same colorectal surgeon for colon cancer. And after surgery, they came to meet me. And they were planned for chemoport insertion on the same day and to start the same type of chemotherapy for the adjuvant treatment of colon cancer. So I asked them, coincidentally, both of you have been detected with the same type of malignancy on the very same day. So then I asked them, what about your family history? Do you have anyone else in the family? Then they said that, yes, their father, who is a family physician, had suffered from colon cancer 20 years back. And now he's completely all right. He has been cured of that cancer and he's still practicing. So they came to ask me now what should be done. So I told them, first you finish your chemos, and after you complete your treatment, then go to a genetic counselor, see which panel. We are suspecting Lynch syndrome in that. So get the test for Lynch syndrome done, so that to know that whether any of your other family members or blood relatives may be affected in future by the same malignancy. So you can be proactive in managing them. So that is one case where genetic test is very important. Another patient, a young lady, 38-year-old lady, who is receiving treatment at our daycare. She was diagnosed with triple negative breast cancer. She completed the treatment for triple negative breast cancer. Then she's a young lady, 38-year-old, and with triple negative aggressive cancer. So we told her to do the BRCA test from the blood. She did the BRCA gene test from the blood, and BRCA1 came positive. When her BRCA1 test came positive, we did the post-test counseling, and then we counseled her that you are very young and you have risk of developing ovarian cancer or fallopian tube cancer or a peritoneal malignancy in future. So better you should go for risk reducing surgery in the form of oophorectomy. And she understood. After a few months, she went for oophorectomy. And when the histopathology report of oophorectomy, we were expecting nothing because the ovaries were just removed prophylactically. But when the histopath report came, she already was having the serous carcinoma of the ovaries, which no one was aware. We just subjected her for prophylactic oophorectomy in view of BRCA test. She came to us with the histopath report. We explained her, see, your ovaries also were having some cancer, which was not detected, but now they are already out, your surgery is complete, and we will see what is to be done. In next 1 month, she came with headache, and her PET scan and MRI brain shows brain metastasis from the triple negative breast cancer. So BRCA1 mutations are very dangerous, and they can lead to a very, very aggressive course. So these two patients I would wanted to share with you, like in whom the genetic tests are very important.
So thank you. Every good thing comes to an end. So let us now break for lunch. Thank you very much. And we see you my next CME. Always tuned to us. Thank you very much.